progress in malaria control has stalled and really perhaps even gone backwards in Africa, especially since 2015, and that's important because it's where 95% of the world's malaria is concentrated. Sorry, I'm trying to, there we go. MSF alone treated 2.7 million cases of malaria in 2020. So if this trend that we see here is to be reversed, improving access to and uptake of proven preventive interventions is going to be key. So today I want to give a high-level overview of several different prevention strategies. First, chemo prevention strategies, then vaccines, and then finally vector control. And I'm going to not try to go too deep into any details, but really want to set the stage for our panelists. We'll get there. Sorry about that. Okay, so in 2020, WHO began a formal review of its malaria chemo prevention guidelines. And this review had a really, really broad scope. And actually, official adoption of parts of the review began last week. And others will be officially adopted later in this year. So one of the overarching themes, though, is to be less prescriptive and giving more latitude to countries to really adopt programs that tailor local epidemiology and their needs. When used at scale, seasonal malaria chemo prevention has about a 70 to 80% protective efficacy in individual children who receive it. So at a population level, when we take into account imperfect efficacy, imperfect coverage, not covering men in season, we actually see up to a 50% reduction in clinical malaria that we see at a population level. MSF was an early adopter of SMC, and SMC has really scaled up massively since we first started introducing it in 2012. But coverage, nonetheless, remains patchy. Happily, concerns about drug pressure selecting for resistant strains of malaria haven't yet materialized. And different countries have begun experimenting with expanding targeted age groups. In Senegal, they treat children up to 10, or expanding the SMC season to cover 5 rounds, like MSF did in Chad. And the text of the new recommendation was released last week, and you see that it's actually become very, very general. There are no specific epidemiological thresholds, not a mention of a specific drug, nor of an age group, nor of even a number of rounds, and instead encouraging countries to be creative and adapt their programs to local needs. So several other strategies have been recommended or soon will be recommended in these new guidelines. And without going into tons of detail on each of them, most of them, I would say, are opportunistic. They give anti-malarials to infants who come to routine vaccination visits or to women receiving prenatal care. And the strategies use different medicines, but they generally involve either 1 or 3 days of treatment with curative anti-malarials. And they've all been shown modestly effective at preventing malaria in all sorts of different contexts in these targeted groups. But all have struggled to be scaled up despite their relative ease of implementation. And I think that's something that I hope that our panelists will discuss a little bit later. And then finally, in the chemo prevention, a subject that Lise talked about was mass drug administration. Now, this strategy consists of giving a full course of therapeutic antimalarials to an entire population, and then often repeatedly. And there's 2 classic use cases. And the first is in very, very low transmission settings, where it's done to further reduce transmission. And this is sort of in a malaria elimination setting. But the second is in a high transmission setting, like in DRC, as Lise was saying, where it's used to really reduce overall disease burden. But overall, and maybe in contrast to some of these other strategies, there's not a whole lot of high-quality evidence on its effect, at least from a broad range of areas. There's certainly likely a beneficial effect, as we've seen, but there is some uncertainty, and it seems like at best the recommendation will be a conditional recommendation for its use in these high transmission settings. So therefore, continuing to document activities like we're doing in the DRC is really, really important. It's critical. So that was a quick run through the chemo prevention strategies, and now on to malaria vaccines. So arguably the biggest news in 2021, or the biggest malaria news anyway, was the WHO recommendation for the use of RTSS, which is the first malaria vaccine to successfully complete phase 3 trials. Now, in the pivotal trial, after 3 doses plus a booster, its effectiveness was approximately 36% at around 4 years of follow-up. And it prevented about 4 in 10 hospitalizations and 3 in 10 blood transfusions, for example. But also, just to point out that this very modest efficacy is actually much higher, up to 70%, for the first 6 months after vaccination. But the modest long-term efficacy actually led to a call to sort of roll out this vaccine in a large-scale pilot, in part to see whether these trial results done in trial settings could be reproduced in real life outside of a trial setting. So this pilot, carried out in Ghana, Kenya, and Malawi, began in 2019, and it's still ongoing. But it's now vaccinated over 1 million children in routine EPI programs, routine vaccinations. And it's basically confirmed the trial results at scale, showing an approximately 30% reduction in hospitalizations due to severe malaria. Importantly, it's proven acceptable to these populations, and it's also helped to reassure that there were no safety issues with the vaccine once it was used at scale. And I think, very interestingly, it's also reached people and reached children who haven't accessed other proven interventions. And I think the best example in the pilot was that 70% of children who didn't sleep under a bed net were able to be vaccinated with RTSS. And then also regarding RTSS, a trial published last year showed some very, very interesting results when RTSS was used with SMC, and it was when RTS was administered seasonally. So the primary series is followed by an annual booster just prior to the rainy season. So the trial was done in Burkina Faso and Mali, and children were randomized to receive SMC alone, seasonal vaccination alone, or both. And over 3 years of follow-up, more or less SMC and RTSS alone were really broadly equivalent. But the combination reduced the risk of malaria by a further 60% compared to either intervention on its own. So perhaps seasonal administration could be a way to mitigate the modest effectiveness of this vaccine. I'm trying. So on the basis of all of this data about this vaccine that we've seen, in October 2021, WHO recommended the use of RTSS in areas of moderate to high transmission, with a 3-dose primary series starting at age 5 months, followed by a booster about a year later. And then just to highlight, those time points don't really correspond to any existing time points in the routine vaccination calendar that exists today. But the recommendation also gave a special call out to areas with seasonal transmission, where these repeated annual boosters prior to the rainy season could be useful. And given the overall stagnation that we've seen in malaria control, despite its challenges, a new tool that could reduce malaria by 30 to 40% is really welcome news. But it's unfortunately not that easy. It's also not that easy to advance the slides. Okay. But for the rest of this decade, supply is going to be extremely limited, perhaps only 15% of demand. And even if we solve the problem of financing, because the vaccine is expected to cost $5 to $7 per dose, there's simply not going to be enough doses to go around. And because of this challenge, WHO is developing this allocation framework that tries to balance ethical principles such as need and impact and equity while staying somewhat transparent and accountable. So countries are going to be asked and invited to apply for these limited doses through Gavi, and also to note, especially for Mimi's point of view, there's not, at this point, provision for independent access for humanitarian actors. So the allocation framework isn't finalized, but one of the key pieces is about how to measure need and how to measure potential impact. And this is the map, one of the maps that they're using on the right, and it combines malaria prevalence with all-cause under-5 mortality. And it really has been proposed as a tool to help prioritize areas for subnational introduction of this vaccine. And the darker purple areas, darkest purple areas, are the highest priority categories. And as you can see, they're often, unfortunately, places with weak health systems and limited resources. So in the in the end, the places that might benefit the most from the vaccine may be the least equipped to roll it out, which I think is going to be a challenge for all of us. And then just a word, there's dozens of other candidate malaria vaccines in the pipeline, but in terms of the ones that are sort of advanced and could potentially be used at scale in the next, well, in the medium term, let's say, the most promising is called R21, and it has a very similar structure to RTSS, using a different adjuvant, but it has phase 2 results that have been very promising, showing, similar to RTSS, a very high short-term efficacy. And first results from a phase 3 trial are expected later this year. But we don't know yet whether the high short-term efficacy that was seen in the phase 2 trial will last over a longer period of follow-up. So we're waiting on those results. But I think one good thing is that the developers have already agreed on a commercialization plan and hope to have the vaccine pre-qualified by 2026, 2027, which could ease some of our supply constraints, particularly regarding RTSS. So that's chemo prevention and vaccines, and now just a few words about vector control. So vector control, bed nets are our cornerstone, and they have proven extremely efficacious over many years. Meta-analysis of trials, including 200,000 children, have shown that bed net use leads to a 50% reduction in malaria and a 17% reduction in all-cause mortality in under 5s. This is a massive effect. But unfortunately, despite big uptake between 2000 and 2015, right now in 2020, only half of African children under 5 are estimated to sleep under bed nets. And for such an effective intervention, 17% absolute reduction in all-cause mortality, that is a scandalously low coverage of such an effective intervention. And lastly, is indoor residual spraying, in French pulvérisation. It has extremely low uptake. Only 5% of African children are thought to have benefited from it in 2020, down from 11% in 2010. With indoor residual spraying, it seems like its effectiveness changes depending on the local epidemiology, but to me, I'm really unclear why it has such a low uptake. It's true that it seems to be logistically heavy, or it's perceived as being logistically heavy, but for example, this is a picture from MSF doing it in Burundi, where they've been doing it for many years. So the new guideline that's coming out did nonetheless make a conditional recommendation for the use of IRS, particularly in humanitarian settings. So, in conclusion, I first want to apologize. I'm conscious that I may have sounded a little pessimistic here at times. Objectively, though, it's reassuring that we have so many potential tools in our toolbox. Granted, they are all imperfect tools. You've seen this in my talk and in the table on the right. And one of the recurring questions we have is how do we pick the right combination in the right place? But right now, the problem isn't that we have imperfect tools or that we've not found the right combinations. And it's simply that we're not using any of them enough or in the right ways. So RTSS is a great addition to our toolbox, but if we want to change the trends in malaria, we need to consolidate the use of all of these imperfect tools in our prevention toolbox that for one reason or another have become less of a priority. So malaria is the #1 pathology that we treat in MSF. I think the question today for our panelists and for everyone in the audience is what we in MSF and around the world could and should be doing to prevent malaria more effectively. So, thank you.